I am Brian Schinder. I am a fourth-year urology resident at Rutgers Robert Wood Johnson Medical School and the Cancer Institute of New Jersey. Thank you to the organizing committee for this invitation to give this talk, and I will be discussing surgical triage during COVID-19. I have no disclosures. These are the objectives for this discussion. So on December 31st, 2019, the coronavirus disease 2019 or COVID-19 was first reported in Wuhan, China. On January 20th, the first case was reported in the United States. By March 11th, the World Health Organization had declared COVID-19 a pandemic. As the cases of COVID-19 quickly rose, significant burdens were placed on healthcare systems, and unprecedented changes ensued. We see here a graph from the CDC where the number of daily cases, new daily cases in the US starting around late February, early March, had a near exponential rise going towards April. So as cases were rapidly rising in the US, we looked overseas for guidance as their experiences preceded ours. At a large tertiary care referral center for urologic diseases in Italy, the large increases in number of cases necessitated a near 30% reduction in urologic surgeries just 2 weeks after the outbreak gave way to a near complete cessation of cases not long after. So why did this happen? Well, as cases rapidly increased, the number of affected patients in our healthcare system caused a shortage of resources, including hospital beds, PPE, and certainly ventilators, given the respiratory nature of the disease. And so we think of it as a sort of balancing act between treating COVID-19 and other diseases such as RCC. We can see how, or can imagine how taking away resources from one of these may shift the scale to the other's detriment. And as we will discuss shortly, we're left in a situation where we really got to think about balancing the preservation of resources to treat COVID-19 against continuing to provide a care for these other diseases. Additionally, social distancing is now a part of everyone's lexicon, and mandates to limit physical interaction to protect both the providers and patients were put into place, especially in the early days of the pandemic when testing was not widespread at all. We really needed to restrict close contact. This is even more true for patients with malignant diseases. They may be more inherently in an immunocompromised state, and this can be compounded by recent systemic treatments or surgical therapy. They may be at an increased risk of not just contracting COVID-19, but if they get COVID-19, having a poor prognosis. And we saw this in a few reports. In this report out of Asia, they see that patients with COVID-19 who also had a cancer diagnosis had an increased risk of requiring ICU admission, invasive ventilation, and death compared to the general population. Additionally, these patients deteriorated more rapidly once they got COVID-19 compared to patients without cancer. And so now we see where these experiences in Italy and elsewhere came from, and why surgical procedures may need to be or may have had to be halted. So in the absence of a complete shutdown of surgical cases, how do we decide which surgeries are allowed to be performed? This comes from the American College of Surgeons, where they note that although we may think of it as rationing resources, and that may be the ultimate effect of having these limited resources, prioritizing or triaging are probably more acceptable terms. So we can start to see where this idea of surgical triage comes from. Additionally, we should probably note that elective surgery is not maybe the most wholly appropriate term. It applies that implies that the timing of surgery can be completely dictated by the surgeon and patient without any consequence. And so the term essential or simply non-emergent is maybe more appropriate. Additionally, the term medically necessary or time sensitive was also coined. So for purely elective cases, things like cosmetic procedures or surgery for PPH in the urologic world, the decision to cancel or postpone surgery is easy. Similarly, for emergent cases where there's a life-threatening or limb-threatening issue, the decision to proceed is also easy. However, for oncologic cases, these decisions are not as clear. Although there aren't often quote unquote emergent oncologic cases, there's certainly often time sensitive component to the surgical approach for these patients. So various groups published guidelines on triaging oncologic surgeries. These guidelines came from a variety of resources, professional societies, peer-reviewed publications, and different individual institutional guidances. And a close look at these guidelines revealed some consistent themes among them, but certainly some critical differences and deficiencies. Looking first at what the American College of Surgeons put forth, which was also adapted by the American Urologic Association, which they termed the elective surgery acuity scale. A close look at this shows that in terms of cancer, they essentially dichotomized cancer recommendations into low-risk cancer, which they say is intermediate acuity and should be postponed if possible, versus most other cancers, which was high acuity and should not be postponed. Clearly, this leaves a considerable amount of room for interpretation, and the nuances of oncologic care not fully captured by this. Simply thinking or thinking about RCC, we can imagine how just simply low risk or other RCC is much too simplistic, and other classifications or clarifications are required. So when looking at the different triage schemas or guidelines, there's near universal agreement that surgery for small renal masses should be deferred in the setting of preserving resources. We know that active surveillance for T1A renal masses is acceptable, given that their metastatic potential is fairly low. And so for patients who are planning to undergo surgery for this disease or T1A disease, we can be fairly confident that a surgical delay should not affect outcomes. We've seen this in prior retrospective analyses. This one, over 6,000 patients were looked at in the SEER database, where those with T1A renal masses undergoing partial radical nephrectomy, there's no difference in mortality when surgery was delayed from diagnosis less than versus greater than 3 months. Additionally, looking at the multi-institutional delayed intervention and surveillance for small renal mass registry, we know there's non-inferiority between active surveillance and intervention, especially when at a short amount of time. And so we can reasonably conclude that a delay of surgical intervention to preserve resources is warranted. We see this bearing out in the various triage schemas that were made available. Small renal masses was universally put into the lowest priority tiers. Guidelines for T1D and T2 RCC, however, is less clear. Surveillance is not generally recommended in these patients, and the surgical removal is standard of care. However, how long to wait until surgery or how long is acceptable to wait until surgery is not fully known. For this reason, there was some heterogeneity among the proposed triage schemas. This comes from Dr. Kudagov's group, who advocated for no delay, highest priority in patients with greater than T1B localized kidney cancer. In this other guideline, while authors suggested delaying T1 masses, T2 tumors were simply recommended to be considered for delay. Finally, in this schema, which was adapted by the British Association for Urologic Surgeons, they classified T1A and T1B RCC to undergo surveillance, while T2 tumors necessitated urgent nephrectomy. Unfortunately, we can see that almost none of these guidelines give much granularity to their recommendations. Terms like high priority and urgent, while help guide decision making, they do not provide a time frame in which it would be safe to delay surgeries if needed. So similar to the wide acceptance for recommendations for small renal masses, there's near universal agreement that surgery for T3 should proceed. Clearly, poor outcomes is associated with this disease or this stage of disease necessitate surgery, and delaying can exacerbate clinical symptoms. And again, in nearly all the schemas, T3 disease was placed in the highest priority tier. So while it was clear that surgery for T3 should be done in a timely fashion, we still have to reconcile that fact that we have to preserve all available resources to help fight the pandemic. So how does performing surgery for something like T3 disease, where a lot of resources would be utilized in that, how does that affect the ability of healthcare systems to handle the COVID-19 surge? This idea brings up, somewhat of an ethical dilemma associated with surgical triage. Peter Angelos wrote about this in a commentary on the subject, that there is a, quote, shift from patient-centered ethics to public health ethics. We go from thinking about what is best for my patient to what is best for the population, or more specifically, or maybe more bluntly, will this operation help my patient versus now, will this operation harm others? We know that if we remove someone's kidney, it will help their cancer status, but will that ability, or will that hinder our ability to potentially treat multiple patients affected with COVID? Additionally, we start to see an incongruity between patients' wishes and a surgeon's ability to provide this care. There's a decreased shared decision making between patients and providers, where normally they mutually agree upon a treatment plan, and this gets now completely shifted to the surgeon to dictate that plan based on available resources. This is likely to be distressing to both providers and patients, especially if patients are unwilling to go along with these plans. This comes from a survey during the peak of COVID of over 500 patients with RCC, where they found that nearly 42% of patients were unwilling to delay surveillance imaging, and only 25% were willing to delay only 1 to 2 months. Additionally, 94% patients reported COVID-related anxiety, in addition to 82%, which had some cancer-related anxiety. So clearly, there's even added stressors to these patients affected with malignancies, and the risk of having to potentially delay their care just compounds the stress. And so as we've talked about, the ultimate goal is to minimize the depletion of resources to combat COVID-19 without unjustly increasing the risk of poor outcomes for patients in need of cancer surgery. So how do we do this? How do we optimize and integrate this idea of resource utilization and oncologic outcomes? The ultimate goal is to combine them into a cohesive triage system. This group attempted to do this. They came up with this medically necessary time-sensitive scoring system, which we see includes procedure factors, disease factors, and patient factors, all of which have a role in not just oncologic outcomes, but also resource management. And so when the scores are tallied up for each surgery or each patient, surgeries that are okay to proceed will be those with more favorable surgical risk, favorable risk to personnel, and minimal resource utilization, where those not justified will be those with worse outcomes, excessive risk to personnel, and more excessive resource utilization. So again, scoring systems like these may limit biases surgeons have when triaging patients, ensure consistency among different surgeons to ensure equitable care, and our quantitative methods for triaging patients which may ease anxiety for the surgeons and patients. So to conclude, COVID-19 rapidly changed how urologic surgeons were able to deliver care to patients. Surgical triage became necessary to select which patients would be able to undergo operations. There may be an increased stress placed on surgeons due to these ethical dilemmas associated with making the surgical triage choices, and further validation of scoring systems to aid in future situations is certainly warranted. Thank you to all my colleagues, and again to the organizing committee for the invitation.